Hello everyone, welcome to my presentation. First of all, let me thank you all for coming here today. As you see on the screen, our topic is hemodynamic disorders. It is the second part of the lecture, and in my presentation I'll focus on few major issues: thrombosis, embolism, infarction, disseminated intravascular coagulation syndrome, thromboembolic syndrome, and so this presentation is structured as follows: thrombosis, definition, predispositions for thrombosis, morphological features and outcomes of thrombosis. Then we go to embolism, again starting with definition, causes, pathomorphology and outcomes. Infarction, definitions, causes, morphological features and outcomes. Then goes disseminated intravascular coagulation syndrome, definition, causes, morphology and outcomes. Thromboembolic syndrome, definition, causes, pathomorphology and outcomes. And at last, shock, definitions, causes, morphological features and outcomes. Let's start with thrombosis. Here on the picture you see the thrombus. So thrombosis is a pathologic process which denotes the formation of a clotted mass of blood within the non-interrupted vascular system. This clotted mass could be seen either within the heart, here you see the heart thrombus, or within the vessels lumen. Since the protective hemostatic plug formed as a result of normal hemostasis is an example of thrombosis. Human beings possess an inbuilt system by which the blood remains in fluid state normally and guards against the hazards of thrombosis and hemorrhage. However, injury to the blood vessels initiates hemostatic repair mechanism or thrombogenesis, in other words, formation of thrombus. Famous pathologist Virchow described three primary events which predispose to thrombus formation, so-called Virchow's triad. Please remember, it is very, very important: endothelial injury, altered blood flow, hypercoagulability of blood. So three main points, three primary events which may help to form the thrombus, predispose to thrombus formation. Influences predisposing to thrombosis are either local or general factors. Local factor, injury to endothelium, and general factors like alterations in normal blood flow, alterations in blood coagulation system, also a general factor. What are the sequence of events in thrombogenesis or formation of thrombus? As I said before, many factors are very important, including endothelial injury, coagulation system, hypercoagulability, altered blood flow, and platelets. So you see here the major factors in pathophysiology of thrombus. Endothelial injury exposes subendothelium-initiated adherence of platelets and activation of coagulation system. Here we see this stage and the upper side of the picture. Then other step following platelet release reaction, ADP is released, which causes further aggregation of platelets. Here we see some aggregation. Before, just few platelets were close to endothelial damage, but later we see more platelets here. They create some aggregations of platelets, and then next step, under letter D, we see the activated coagulation system, which forms fibrin strands here, in which are entangled some leukocytes, red cells, and tight meshwork, which called then thrombus. So the whole meshwork with fibrin, leukocytes, red cells, and other cells, all these mass called thrombus. Here we see the examples of endothelial injuries. On the top, you see here the aorta with the areas of damage. You see some injuries in intima and some blood clots on the top of such injuries. And these injuries predispose to aggregations of blood cells and fibrin formation with further formation of thrombus. And here under number 1 we see a thrombus, and on the top also tiny thrombi, hemorrhages and thrombi on the top of the lesion. We see here the picture of the artery with, in case of atherosclerosis, and arrow shows that the atherosclerotic plaque ruptured, and plaque rupture without superimposed thrombus in patients who died suddenly. But anyway, arrow shows the damage of the plaque cap. Few words about role of the platelets. Following endothelial cell injury, platelets come to play a central role in normal hemostasis as well as in thrombosis. So here you see the sequence of events. So you see activation of platelets, starting with non-activated platelet, then earlier it has a phase, then platelet release reaction, they release granules, and then at the end platelet aggregation. So we see step-by-step activation of platelets during hemostatic plaque formation and thrombogenesis, starting from the normal non-activated platelet, having open canalicular system and cytoplasmic organelles dispersed in the cells. Then at early adhesion phase, we see a dilation of the canalicular system with formation of pseudopores and the organelles present in the center of the cells. Then we see the platelet release reaction, as I said before, which release granules to exterior area, and at the end we see the plaque formation. Coagulation mechanism is the conversion of the plasma fibrinogen into solid mass of fibrin. The coagulation system involved in both hemostatic process and thrombus formation very important. Here in this picture we see the schematic representation of the cascade of intrinsic blood pathway, the extrinsic tissue pathway, and the common pathway leading to formation of fibrin polymers. So various pathways with which includes few components: tissue factor, then blood factor, which activate the cascade at the end with fibrin from. Alteration of blood flow are also alterations also of blood flow important. Normally there is the axial flow of blood, in which the most rapidly moving central stream consists of leukocytes and red cells. Here you see the normal axial flow in the center, the top of the picture. So central stream, and we see here red cells, and we see leukocytes. Also we see some platelets. And periphery of the blood flow is the plasma zone. Here we see this pinkish area is plasma. Turbulence and stasis occur in thrombosis, in which the normal axial flow of blood is disturbed. When blood slows down, the blood cells, including platelets, marginate to the periphery and form a kind of pavement close to endothelium. We call it margination and pavementing. While stasis allows a higher release of oxygen from the blood, turbulence may actually injure the endothelium, resulting in deposition of platelets and fibrin. Formation of arterial and cardiac thrombi is facilitated by turbulence in the blood flow, while stasis initiates the venous thrombi, even without evidence of endothelial injury. So turbulence means unequal flow, while stasis means slowing. And so both alteration may cause the blood flow. Here we see the turbulence or unequal flow of the blood within the varicose veins. So we see here varicose veins, and such situation, clinical situation, may result in intravenous thrombi, and the outcome could be unfavorable in that case when we see the thromboembolism as a result of such changes. The next predisposing factor, hypercoagulability of blood. It includes the increase in coagulation factors, like for example, fibrinogen, prothrombin factor 7, 8, and XA, then increase in platelet count and their adhesiveness, decreased levels of coagulation inhibitors like anti-thrombi, 3, fibrin split products, and others. The occurrence of thrombus in some conditions, such as in nephrotic syndrome, advanced cancers, extensive trauma, burns, and urine puerperium, is explained on the basis of hypercoagulability of blood. The effects of hypercoagulability on thrombosis is favored by advancing age, smoking, use of oral contraceptives, and obesity. Hypercoagulability may occur by the following changes in the composition of blood. What are the causes of thrombus formation? Stasis in case of heart failure, chronic venous insufficiency, injury, trauma, surgery, parturition, hormonal imbalance, like in case of oral contraceptive use, advanced age, immobilization, for example, orthopedic paralysis, bed rest. Sickle cell disease, for example, may cause this formation. You must remember features of thrombia which are characteristic for various types of thrombia when studied by naked eye. There are a few types of thrombia: white thrombus, red thrombus, mixed or laminated thrombus, hyaline thrombus, and agonal thrombus. Thrombosis may occur in heart, arteries, veins, and the capillaries. Beside the differences in mechanism of thrombus formation, besides the clinical effects of these are even more different. Arterial thrombi produces ischemia and infarction, whereas cardiac and venous thrombi cause embolism. What are the general morphological features? Look here on the picture. The right side of this slide, we see grossly that inside the vessels, it is water, and we see some injuries of the endothelial layer, and we see a thrombus inside the aorta, and it is mixed, laminated. So grossly, thrombi may be of various shapes, sizes, and composition depending upon the site of origin. Arterial thrombi tend to be white and mural, while the venous thrombi are red and occlusive. Mixed or laminated thrombi are also common and consist of alternate white and red layers called lines of Zachen. Red thrombi are soft, red, and gelatinous, whereas white thrombi are firm and pale. Under microscope, the composition of thrombus is determined by the rate of blood flow. So whether it is formed in the rapid arterial and cardiac circulation or in the slow-moving flow in veins. The lines of Zachen are formed by alternate layers of light-staining aggregated platelets admixed with fibrin meshwork and dark staining layer of red cells. Red venous thrombia have more abundant red cells, leukocytes, and platelets interrupt in fibrin meshwork. Thus, red thrombi closely resemble blood clot. So here you see the thrombus in an artery. The thrombus is adherent to the arterial wall and is seen occluding most of the lumen. It shows lines of Zachen composed of granular-looking platelets and fibrin meshwork with entangled red cells and leukocytes. So remember, we see in red thrombus platelets, fibrin, erythrocytes, and these thrombi usually seen in veins due to rapid formation and slow blood circulation, slow So slow blood circulation and rapid formation of the thrombus. We see such situation in veins. And grossly, they are dark red color. So we see these dark red colored dry masses with deep surface. At high magnification, the dark red thrombus is apparent in the lumen of the coronary artery. The yellow tank plaques of atheroma narrow the coronary significantly, and the thrombus occludes it completely. So here you see atheroma, and here you see the atheromatous changes of the artery, which narrows the coronary artery lumen. And also here you see the thrombus, which occludes completely the artery. And of course, as a result of such occlusion, the cardiac infarction could be formed. White thrombus, it consists of platelets, fibrin, leukocytes, and usually it forms slowly in rapid circulation of the blood. We see such thrombus usually in artery. Mixed or laminated thrombus. It contains white and red elements of thrombus, usually forms in vein, aneurysms of aorta and heart. Consists of head, white thrombus, body, white and red, and tail. Has construction of red thrombus. So head is white thrombus, body white and red, and tail a red thrombus. And it's called mixed or laminated thrombus. You must know that head is connected with endothelium. Here you see the laminated or mixed thrombus. You see the components in the heart. You see the components, both red and white thrombus, and we call it mixed thrombus. If we look under microscope, like here in this picture, you see here the picture of high magnification cross-section of the artery. You see number 2. It's a tiny piece of the wall of the vessels, and all picture is a mixed thrombus. You see erythrocytes, you see other cells like leukocytes, platelets, and tiny strains of fibrin, which creates sort of meshwork, and all blood cells are within this meshwork. Hyaline thrombus consists of precipitating plasma proteins, some destructed erythrocytes, then leukocytes, thrombocytes, and it resembles hyaline and located usually in microcirculatory band. So in tiny capillaries, for example. And please pay attention, they do not contain fibrin. Here on this table we see features of arterial and venous thrombi, and they are quite different. So arterial thrombi formed in rapidly flowing blood of arteries and heart, and venous thrombi formed in slow-moving blood. So it is usually seen in veins. Usual sites: arterial thrombi common in aorta, coronary, cerebral, iliac, femoral, renal, and mesenteric arteries, and venous thrombi common in superficial, varicose veins, deep leg veins, popliteal, femoral, and iliac veins. So in various sides of the body, in various veins. Thrombogenesis: arterial thrombi formed following endothelial cell injury. As usual example is atherosclerosis. Venous thrombi usually formed following venostasis. For example, in case of abdominal surgery, childbirth, we can have such situation with venous thrombosis. Development: in case of arterial thrombi, usually mural, not occluding the lumen completely, and may propagate. Venous thrombi usually occlusive, take the cast of the vessel in which formed, may propagate in both directions. Grossly, arterial thrombi great white, friable, with lines of Zachen on the surface. Venous thrombi red-blue, grossly, with fibrin strands and lines of Zachen. Under microscope, distinct lines of Zachen composed of platelets, fibrin, and entangled red and white blood cells. Lines of Zachen with more abundant red cells are common in venous thrombi. The effect of arterial thrombi: ischemia leading to infarcts, for example, in heart, brain, and other organs. Venous thrombi may cause thromboembolism, edema, skin ulcers, and poor wound healing. Agonal thrombus consists of yellowish fibrin, localizes in the apex of the right ventricle of the heart and may extend into pulmonary artery. It is formed in the last minutes of the life when the death occurs slowly. And red clot forms in case of rapid death. You must distinguish features of antemortem, it means before the death, and post-mortem clots. It is very important to know when you make the dissection or autopsy of the dead body. And pathologists might answer the questions whether the thrombus antemortem before death of the patient or post-mortem. So antemortem thrombi, grossly dry, granular, firm, and friable. Post-mortem clots, gelatinous, soft, and rubbery. Relations to the vessel wall: antemortem thrombi adherent to the vessel wall, and post-mortem ones weakly attached to the vessel wall. Shape: may or may not fit their vascular contours, and post-mortem clots take the shape of the vessel of its bifurcation. Microscopically, the surface contains apparent lines of Zachen, and post-mortem surface is chicken fat, yellow, covering the underlying red currant jelly. So again, the most important features: white-red mixed thrombus connected with endothelium, dry crumbled masses, dim surface grossly, and agonal thrombus or post-mortem. They are not connected with endothelium, soft, elastic, and have the brilliant surface with naked eye examination. Here you see the gross specimen of the soft tissue of the leg. We see blood clots in the deep veins of the lower extremities. The lumen of the vein here you see completely obturated or occluded with dark red dry masses tightly soldered to the tightly attached to the vessel wall. This situation is very important, and it could be a result in fatal outcome due to thromboembolism. Again, the picture you have already seen with mixed thrombus under a microscope. So outcomes of the thrombus could be favorable or unfavorable outcomes. So here you see the fate of thrombus or outcome. Fate of thrombus could be resolution. It's a wonderful outcome. It could be organization. It could be propagation and embolism. The favorable outcomes have few positions, like resolution. We call it aseptic autolysis or autolysis, organization or connective tissue replacement, recanalization, vascularization, and petrification. So here under microscope we see the atherosclerotic plaque of the carotid artery and arterectomy specimen with a large mural thrombosis. So here you see the thrombus which attached to atherosclerotic plaque. Here you see the atherosclerotic plaque, and here the right part of this picture is thrombus. Here you see atheroma, again in case of atherosclerosis, and black boundary present you the piece of thrombus which occluded the lumen of such artery, but with time it is replaced by connective tissue. We call it organization. Then we see some new small lumina formation, and we call it recanalization. And then with time we see endothelium within these canals, and endothelial cells cover the inner layer of these canals, and we call it revascularization. So under high magnification we see agonizing thrombus which occluded the vessel's lumen. Here you see the vessel's lumen filled with thrombotic masses. So with time we see the growth of connective tissue. Here under number 2 we see some pieces fossil of such area. Slits lined with endothelium. Here we see the endothelium and connective tissue growth, and tiny fibers of fibrin, some blood cells, And with time we see the new vessels formation. At the beginning they are canals, and then they have the layer of endothelial cells and convert into the vessels. There are few unfavorable outcomes or fates of thrombus. The first one is thromboembolism, then goes septic autolysis, and propagation with following obstruction of some critical vessels. Now we go to other section, embolism. Embolism is the process of partial or complete obstruction of some part of cardiovascular system by any mass carried in the circulation. The transported intravascular mass detached from its site of origin is called an embolus. Most usual forms of emboli, 90% of them, are thromboembolic. So they originate from thrombi or their parts detached from the vessel's wall. We must classify embolism upon the matter in the emboli. They could be solid, so pieces of detached thrombi in case of thromboembolism, atheromatous material in case of atherosclerosis, tumor cell clumps, tissue fragments, parasites, bacterial clumps, and foreign bodies. Emboli could be liquid, for example, in case of fat embolism, amniotic fluid, and bone marrow. And at the end, gases, air, and other gases. Depending upon whether infected or not, they could be bland when sterile, septic when infected. Depending upon the source of the emboli, cardiac emboli from left side of the heart, originating from atrium and atrial appendages, infarct in the left ventricle, vegetations of endocarditis, arterial emboli in systemic arteries in the brain, spleen, kidney, and intestine, venous emboli, for example, in pulmonary arteries, and lymphatic emboli can also occur. Depending upon the flow of blood, two special types of emboli are mentioned. Paradoxical embolus. An embolus which is carried from the venous side of circulation to arterial side or vice versa is called paradoxical or crossed embolus. So through arteriovenous communication, such as in patent foramen ovale, septal defects of the heart, and arteriovenous shunts in the lungs. Retrograde embolism is an embolus which travels against the flow of blood, and it is called retrograde embolus. And metastatic deposits in the spine from carcinoma prostate could be the example of such embolism. The spread occurs by retrograde embolus through intraspinal veins which carry tumor emboli from large thoracic and abdominal veins due to increased pressure in body cavities. For example, due to coughing or straining, which may cause the retrograde embolism. So you must remember of possible clinical situation in various important sites. Pulmonary embolism, common origin, veins of lower legs. Um, it means that when we make the autopsy and we see pulmonary embolism, pathologist must make a section of the lower legs veins. Systemic embolism due to left ventricle thrombosis, the arterial thrombium, fat embolism due to trauma, trauma to bones or soft tissues, air embolism, venous origin in case of head and neck operations. The other example, obstetrical trauma, arterial air embolism, cardiothoracic surgery, angiography may cause air embolism. Decompression sickness, in case of descent divers and in case of ascent pressurized flight also could be the example of such disease. Amniotic fluid embolism by components of amniotic fluid during labors or giving birth. Atheroembolism may be caused by destruction of atheromatous plaque. And tumor embolism, tumor fragments may cause the embolism, which may result in metastatic foci of tumor formation. According to the material of the embolism, as I said before, they could be solid, liquid, and gases, various gases. Solid thromboembolism, atheroembolism, tissue fragments, tissue or cells. It may be due to necrosis of the tumor, damaged tissue, bacterial embolism, embolism by parasites, embolism by foreign bodies. All these emboli are solid. Liquid emboli may be caused by amniotic fluid embolism and fat embolism. Here you see the example of amniotic fluid embolism. Within the vessel, we see the occlusion of such vessels by the component of amniotic fluid. And on the top right, we see some accumulations of the fat within the vessel. These vessels occluded by fat emboli, and this may be a result of trauma of soft tissue and bones which cause fat emboli. Amniotic fluid embolism, this is the most serious cause of maternal mortality. The contents of amniotic fluid may enter the uterine veins and reach right side of the heart, resulting in fatal complications. In the lung, we may see hemorrhages, congestion, edema, dilatation of right side of the heart. All these may help to make right diagnosis. Fat embolism caused by trauma, inflammation of the bones and soft tissue, fatty liver, pancreatitis, extrinsic fat or oils introduced into the body patient. Fat embolus caused particular hemorrhages in the white matter throughout the brain, resulting in coma and death. So here you see on the gross specimen, the cross section of the brain, and please pay attention for many tiny petechial hemorrhages. And the patient, as I said before, died due to coma. Here you see the example of fat embolism. Under microscope, we see the sample of the tissue, lung tissue, and under here you see the alveoli filled with air, and under number 1 we see interalveolar septi with vessels occluded by fats, and we see such fats due to special staining Sudan 3, and Sudan 3 stains fat in yellowish orange color. Microscopically, the lungs show hyperemia, edema, petechial hemorrhages, changes, clinical symptoms of adult respiratory distress syndrome. Pulmonary infarction is usually not a feature of fat embolism because of the small size of globules. In routine stains, the fat globules in the pulmonary arteries, capillaries, and alveolar spaces appear as vacuoles. So when we see the vacuoles, we must distinguish such pathology from vacuolar dystrophy, and special staining may be helpful. So frozen section is essential for confirmation of globules by fat stains such as Sudan dyes, Sudan black, and Sudan 3 and 4. Osmic acid also could be helpful in staining. Decompression sickness or caisson disease may be a result of various changes in tissues due to gaseous embolism and air embolism. We'll discuss these pathologies. Decompression sickness, this is a specialized form of gas embolism, caisson disease or diver's palsy or aeroembolism. Decompression sickness is produced when the individual decompresses suddenly, either from high atmosphere pressure to normal level or from normal pressure to low atmospheric pressure. Causes of arterial air embolism: cardiothoracic surgery, trauma, paradoxical air embolism, and arteriography. Other causes of venous air embolism are operations on the head and neck, trauma, obstetricals operation, intravenous infusion of blood and fluid, and such medical procedure as angiography. Few words of thromboembolism. A detached thrombus or part of thrombus constitutes the most common type of embolism. These may arise in the arterial or venous circulation. Excuse me. right part of this slide, we see under letter A and B, you see lung thromboembolism, so thrombia within the lung, and under letter B, we see microscopic picture of lung thromboembolism. You must remember important types of embolism. Arterial thromboembolism in heart, most common. We see mural thrombia in left atrium, left ventricle. Vegetative mural endocarditis may cause such pathology, valvular endocarditis, prosthetic heart valve, cardiomyopathy. In lungs, pulmonary veins could be involved. Systemic arterial thromboembolism could be diagnosed in case of aortic atherosclerosis, carotid atherosclerosis, aortic aneurysm. Systemic venous thromboembolism may result of deep vein thrombosis, most common feature, pelvic veins, cavernous sinus, heart, particularly right side of heart, may cause venous thromboembolism, and pulmonary artery of lung. Arterial or systemic thromboembolism may be caused by various pathology. For example, within the heart, 80–85%, these thrombia, mural thrombia in the left atrium of left ventricle, vegetations of the mitral or aortic valves, prosthetic heart valves, and cardiomyopathy may cause the thromboembolism from the arterial side, the systemic arterial thromboemboli. Causes within the arteries. These include emboli development in relation to atherosclerotic plaques, aortic aneurysms, pulmonary veins, and paradoxical arterial emboli from the systemic venous circulation. The effects of arterial emboli are different, depend upon the sites of emboli, site of lodgement, adequacy of collateral circulation. All these are important. If the vascular occlusion occurs, the following ill effects may result. First of all, infarction of the organ or its affected part. For example, ischemic necrosis in the lower limbs, 70–75%. Spleen, kidneys, brain, intestine also could be involved. Gangrene following infarction of the lower limbs if collateral circulation is inadequate. Arteritis and mycotic aneurysm formation from bacterial endocarditis. Myocardial infarction may occur following coronary embolism. Sudden death may result from coronary embolism or embolism in the middle cerebral artery. Venous emboli may arise from the following sources. Thrombi in the veins of the lower legs are most common cause of venous emboli. Thrombi in the pelvic veins, also important. Thrombi in the veins of the upper limbs. Thrombosis in cavernous sinus of brain, and thrombi in the right side of the heart. Here you see the pulmonary thromboembolism. Pulmonary embolism is the most common and fatal form of venous thromboembolism, in which there is occlusion of pulmonary artery tree by thromboemboli. Here under number 1 we see such thromboemboli within the lumen of the pulmonary artery. Pulmonary embolia are more common in hospitalized or bedridden patients, though they can occur in ambulatory patients as well. The causes are as follows: thrombi originating from large veins of lower legs, such as popliteal, femoral, and iliac, and they are the cause of 95% of pulmonary emboli. Less common sources include thrombi in varicosities of superficial veins of the legs and pelvic veins, such as periprostatic, periovarian, uterine, and broad ligament vein. All of them may cause pulmonary embolism. What are the consequences of pulmonary embolism? Sudden death, acute cor pulmonale, pulmonary infarction, resolution if the area is not so big, pulmonary hypertension, chronic cor pulmonale, pulmonary atherosclerosis, and pulmonary hemorrhage. Causes, excuse me for mistake, causes are as following: stasis in case of heart failure, chronic venous insufficiency, injury in case of trauma, surgery, parturition, hormonal imbalance in case of oral contraceptive use, advanced age, immobilization in case of orthopedic, paralysis and bed rest, and sickle cell disease. I also mentioned the causes. Again, the same picture of pulmonary embolism. Here you see the large embolism. Here you see the embolus derived from a lower extremity deep venous thrombosis and now impacted in a pulmonary artery branches. Atheroembolism. Again, the same picture. We see the coronary artery, and arrow shows the damage in the cup of atheromatous plaque. So atheromatous plaques may get eroded and form atherosclerotic emboli. Parasite emboli may block small vessels, such as the cerebral vessels in case of malaria. Here you see the tissue sample of the brain and histology of a brain from a patient with cerebral malaria, showing sequestration of parasites, pigmentation, and obstruction of blood vessels. Here, such a tiny blood vessels like this. Neoplastic emboli shown here, and the picture, right picture, and you see the vessel filled with thrombus made of neoplastic cells, and we see even the growth outside the capsula around such focus. So fragments of malignant tumor are liable to infiltrate venous and lymphatic channels, and then break off to lodge elsewhere in the body. Neoplastic emboli is of great importance in spread of malignant tumor. Now we go to infarction. Infarction is the process of tissue necrosis resulting from some form of circulatory insufficiency, and the localized area of necrosis developed called an infarct. Causes are quite different. Most commonly, infarcts are caused by interruption in arterial blood supply called ischemic necrosis. Less commonly, venous obstruction can produce infarcts termed stagnant hypoxia. General, sudden, complete, and continuous occlusion, so thrombosis or embolism, produces infarction. Infarcts may be produced by occlusive circulatory insufficiency, as well incomplete atherosclerotic narrowing of coronary arteries, and as a result we see myocardial infarction and acute coronary insufficiency. Yet types of infarcts are different. They are classified depending on various features. First, according to the color, they could be pale or anemic due to arterial occlusion and are seen in compact organs such as kidney, heart, and spleen. Infarcts could be red or hemorrhagic, seen in the soft, loose tissues, and are caused either by pulmonary arterial obstruction. For example, we see such red or hemorrhagic infarct in the lungs, or the same we see by arterial venous occlusion, for example, in intestines. According to the age of infarct, they could be recent or fresh, they could be old or healed. Also, we may classify infarcts according to the presence or absence of infection: bland when free of bacterial contamination, and septic when infected. Infarcts of most commonly affected organs looks like quite different. Myocardial infarction, very important gross characteristics. So gross appearance of myocardial infarction are pale, with hemorrhagic rim around it. Frequently lethal outcome of such infarction. Pulmonary infarction are hemorrhagic ones, less commonly fatal. Cerebral infarction could be hemorrhagic or pale. They are fatal if massive. Intestinal infarction, they are hemorrhagic and frequently lethal. Renal infarction, pale, not lethal unless massive and bilateral. Infarct of spleen, they are pale, not lethal. Liver infarcts, pale, not lethal. And infarcts of lower extremities are pale and not lethal. So, not fatal outcome. Morphological features. Grossly, infarcts of solid organs are usually wedge-shaped, the apex pointing towards the occluded artery and the wide base on the surface of the organ. Infarcts due to arterial occlusion are generally pale, while those due to venous obstruction are hemorrhagic. Most infarcts become pale later as the red cells are lysed, but pulmonary infarcts never become pale due to extensive amount of blood. Cerebral infarcts are poorly defined with central softening encephalomalacia. Recent infarcts are generally slightly elevated over the surface, while the old infarcts are shrunken and depressed under the surface of the organ. Microscopically, the pathognomic cytological change in all infarcts are coagulative ischemic necrosis of affected area of tissue and organ. In cerebral infarcts, however, there is characteristic liquefactive necrosis. Some amount of hemorrhage is generally present in any infarct. At the periphery of an infarct, inflammatory reaction is noted. Please remember, the periphery surrounded by inflammatory reaction. Cells, inflammatory cells, hyperemic vessels, blood circulation disturbances, etc. Initially, neutrophils predominate, but subsequently macrophages and fibroblasts appear. Eventually, the necrotic area is replaced by fibrous scar tissue, which at times may show dystrophic calcification. In cerebral infarcts, the liquefactive necrosis is followed by gliosis, so replacement by microglial cells, distended by fatty material, and we call them glials. Look here, you see a nice picture of the lung tissue sample, gross picture, cross-section, and on the right side of the sample we see the hemorrhagic infarction. Grossly pulmonary infarcts are classically wedge-shaped with base on pleura, hemorrhagic variable in size, and most often in the lower lobes. Pleuritis usually covers the area of infarction. Cut surface is dark purple and may show the blocked vessels near the apex of the infarcted area. So here, for example, we see here and here, we see the thrombi. Old, organized, and healed pulmonary infarcts appear as retracted fibrotic scars. Under microscope, the characteristic histological features are following. We see coagulative necrosis of the alveolar walls. Initially, there is infiltration by neutrophils and intense alveolar capillary congestion, but later their place is taken by hemocybidin, phagocytes, and the granulation tissue. So here we see the lung parenchyma on this picture showing hemorrhagic infarction. You see a lot of erythrocytes, a lot of hemorrhages, and destruction of interalveolar. Here you see the infarct of kidney, gross specimen of the kidney with the cross section of such specimen. Grossly renal infarcts are often multiple, but sometimes just one infarct. Characteristically, they are pale or anemic and wedge-shaped with base resting under the capsule and apex pointing towards the medulla. Generally, a narrow rim of preserved renal tissue under the capsule is spared because it draws its blood supply from the capsular vessels. Gut surface of renal infarct in the first 2 to 3 days is already congested, but by 4th day the center becomes pale yellow like we see here. At the end of 1 week, the infarct is typically anemic and depressed below the surface of the kidney when we look at surface from the capsule. Here you see microscopical picture of kidney infarction. On the left side of such picture, here, you see the area of the infarction. Microscopically, the affected area shows characteristic coagulative necrosis of renal parenchyma. So there are courses of renal tubules and glomeruli without intact nuclei and cytoplasmic content. The margin of the infarct shows the inflammatory reaction, initially acute but later macrophages and fibrous tissue predominant. So here you see the infarction, and also pay attention that between the preserved tissue and infarction, we see the cell infiltrates as a result of inflammatory reaction. Splenic infarct. Grossly, splenic infarcts are often multiple. They are characteristically pale or anemic and wedge-shaped with their base at the periphery and apex pointing towards hilum. Microscopically, the features are similar to those found in anemic infarcts in kidney. Coagulative necrosis and inflammatory reaction are seen. Later, the necrotic tissue is replaced by shrunken fibrous scar. The next picture is the infarct of liver. Infarcts in the liver are uncommon due to dual So here on the right part of this slide, you see the gross specimen of the liver, cross section, and you see grossly ischemic infarcts of the liver, which are anemic. By the way, sometimes they could be hemorrhagic due to stuffing of the site by blood from the portal vein. Non-ischemic infarcts, or infarcts of Zach, produce sharply defined red-blue area in liver parenchyma, but here you see the ischemic infarct, definitely some infarction, ischemic infarction. Microscopical ischemic infarcts show characteristic of pale and anemic infarct, like in kidney and spleen. Infarcts of Zahn occurring due to reduced portal blood flow over a long duration result in chronic atrophy of hepatocytes and dilation of sinusoids. Now we go to shock. Shock is defined as a clinical state of cardiovascular collapse characterized by an acute reduction of effective circulating blood volume and an inadequate perfusion of the cells and tissue. According to etiology and pathogenesis, shock is classified as hypovolemic, cardiogenic, septic, anaphylactic, neurogenic, shock developing in hormonal insufficiency. What we see under microscope, We see the generalized spasms of the vessels, microthrombosis, signs of increased vascular permeability in microcirculatory system. We see hemorrhages, degenerations. We see multiple necroses connected with hypoxia and damaging effect of endotoxin. Here, this is the example of shock kidney. You must remember that shock kidney presented with degeneration and necrosis in proximal canals, and as a result, we see acute renal insufficiency. You see here on such picture the pale cortex and congested medulla. We see here the picture of shock liver. Microscopically, we see hydropic degeneration and central lobular necrosis. Here you see the area of necrosis. You can't see any boundary of the cells, just tiny fragments of the cell nuclei. So these are areas of necrosis and some preserved but dystrophic hepatocytes. So as a result of such pathology, we see the acute hepatic insufficiency symptoms. Combination of renal and hepatic insufficiency is called hepatorenal syndrome. Shock lung characterized by atelectasis, serous hemorrhagic edema, stasis and thrombosis in the microcirculatory vessels, and all these morphological changes result in acute respiratory insufficiency. Shock heart. Under microscope, we see degeneration and necrosis in cardiomyocytes, fat degeneration, and necrotic foci. Not special gross picture because it's acute situation. In shock brain, we see hypoxic changes. Ischemic neurons appear shrunken and have eosinophilic cytoplasm, like here. You see few necrotic neurons. The pericellular spaces are dilated because of edema. You see these transparent areas are pericellular edema. So we see neuronal necrosis in the area. Now we go to disseminated intravascular coagulation. Disseminated intravascular coagulation, also termed defibrillation syndrome or consumption coagulopathy, and it is a complex thrombohemorrhagic disorder. So we see both intravascular coagulation and hemorrhages occurring as a secondary complication in some systemic diseases. So commonly disseminated intravascular coagulation syndrome is a result of other severe pathologies. We see massive tissue injury in obstetrical syndromes, for example, abruptio placenta, amniotic fluid embolism, retained dead fetus, massive trauma, metastatic malignancies in surgery. Such situation may cause DIC syndrome. Various infections, especially endotoxemia, gram-negative and meningococcal septicemia, certain viral infections, malaria, aspergillosis, may result in complication with disseminated intravascular coagulation syndrome. Other causes: widespread endothelial damage, for example, in aortic aneurysm, hemolytic uremic syndrome, severe burns, acute glomerulonephritis, and at the end, for example, other causes like snake bite, for example, may cause such syndrome. Here in this picture, we see some explanation of the pathogenesis of disseminated intravascular coagulation. We see here the endothelial damage, then activation of coagulation, and then platelet aggregates formation, then thrombotic phase, and the microthrombia are formed in circulation, and then the consumption phase, when we see overconsumption of thrombotic factors, which may cause secondary fibrinolysis. So here you see intravascular coagulation, starting with tissue injuries, like in case of obstetrical complications, in case of various malignancies, massive trauma, burns, surgery, also severe infection pathologies complicated by sepsis, gram-negative and other infections, endothelial injury in case of aortic aneurysm, as I said before, hemolytic uremic syndrome, burns, and glomerulonephritis. In first two groups, tissue thromboplastin and then extrinsic coagulation pathway stimulate intravascular coagulation, and in case of endothelial injury, as I have already shown you the picture before, the platelet aggregations, and then we see intrinsic coagulation pathway, but all of them, they stimulate intravascular coagulation. So the consumption of clotting factors and platelets, then plasmin activation, fibrinolysis, and microvascular occlusions, they all cause bleeding, ischemic tissue injury, and microangiopathic hemolytic anemia in various pathologies which are caused by various reasons, various etiology, like inhibit platelet aggregation, thrombin and fibrin polymerization may result with combination of overconsumption of clotting factors cause bleeding, and microvascular occlusion of course result in infarction, and also it may cause the in case of hemolytic uremic syndrome, microangiopathic hemolytic anemia. clinical features. There are two main features of the syndrome: bleeding as the most common manifestation, and organ damage due to ischemia caused by the effect of widespread intravascular thrombosis, such as in the kidney and brain. So, first of all, we see bleeding. Less common manifestations include microangiopathic hemolytic anemia and thrombosis in larger arteries and veins. So here you see the kidney in DIC syndrome. Look, the pale cortex and congested hyperemic pyramids. And on the right, you see a lot of congested vessels, a lot of hemorrhages, necrosis, and also thrombosis of some capillaries. Here you see the lungs with thrombosis of the vessels and also a lot of hemorrhages. Here you see thrombi in capillaries of the lungs. You see lung tissue under high magnification. Here you see the air in alveoli, and here you see the vessels in alveoli septi with thrombi in their here you see the brain tissue with some thrombi in the vessels, and of course here look, perivascular edema, here also edema, and in this picture we see edema due to increased permeability. So this is the end of my presentation. Thank you all for your attention.